At the end, Dr. Waleed, as usual. Nice
My dear
start.
my professor, ربنا يبارك فيك. Thank you. Let me share the screen.
As you may all know, Prof. Waleed Hamimy is a professor of anesthesia and intensive care and dream medicine in Cairo University, Qasr Al Aini, Egypt. And he is one of the star speakers tonight, and he is going to talk to us about spinal anesthesia for ambulatory surgery, COVID era. Prof. Waleed, all yours. Thank you so much for being here tonight.
Thank you, Dr. Saad, and I want to thank Dr. Muhammad Abdurrahman for inviting me to this very, very eminent lecturers, and I was delighted to hear Dr. Muhammad Abdulatif, and it's very hard to talk after him. I will try to speak fast because we are running out of time. The title of the lecture is Spinal Anaesthesia for Ambulatory Surgery, especially in the COVID era that we are living in. Epidural and spinal anesthesia have developed and increased in popularity in the inpatient population, specifically in the obstetrics and major joint arthroplasty over the last 30 years. Traditionally, the quick general anesthesia has been the option of most other procedures. Spinal anesthesia was rarely offered as a choice, particularly in the ambulatory setting. The French Society of Anesthesia published in a survey that has been done including 703 anesthetists. The objective of this investigation was to evaluate the practice of spinal anesthesia among French anesthetists in inpatient and outpatient settings. And spinal anesthesia was usually performed, they found that spinal anesthesia was usually performed in the sitting position using a Whittaker needle with a 25 gauge diameter. Ultrasound before puncture was only reported in 26% of cases due to obesity and spinal abnormalities. And they found also that spinal anesthesia was typically proposed in only 29 to 49% of cases. And BUPIVACAINE was the most used local anesthetic. And the reasons for choosing general anesthesia was the delays in attaining readiness for hospital discharge, urine retention, operation length, and the surgeon's preference. But now, in the COVID era, John Kennedy had a quotation, or quote, that in a crisis, we should be aware of the danger, but recognize the opportunity. Of course, COVID-19 is very serious, it's a very fatal disease, but thanks to the this COVID disease, in recognizing the benefits of regional anesthesia, and it has been published in the British Journal of Anesthesia last year that regional anesthesia in the era of COVID-19 is the first choice at last for administering anesthesia for patients. As we all know, transmission of COVID is through droplets or direct contact or from touching shared objects. There are no known cases of established fecal oral transmission. The factors that should be considered in this COVID era is the proximity to the patient. We should not stay near the patients. The distance between them, between the physician and the patient should be kept more than a meter. The duration of exposure is also important, and whether the patient actually has COVID-19. I myself consider all patients are suspected of COVID-19 until proved otherwise. So we should manage our patients as if they are COVID-19 patients. The number of air changes in the operating room, and lastly, the question of droplet format and or aerosol spread is very important to be considered in this era. This figure shows the difference between droplet transmission and airborne transmission. Droplet transmission by coughs and sneezes while airborne transmission is the tiny particles that are produced by talking, which is very serious. In the COVID-19 pandemic, challenges for anesthesia included that manipulation of the airway being an aerosol generating procedure, of which subsequent aerosolization can potentially infect healthcare workers. Another aspect that is considered as a challenge is the unprecedented demand for anesthetic drugs for use in the critical care. ICUs are fully occupied, and sedation, sedative drugs, and all the analgesics are given in the ICUs. This reduced the availability of these drugs. Our lecture is about ambulatory surgery. What is ambulatory surgery? In the UK, ambulatory surgery refers solely to the patients being discharged from the hospital shortly after surgery, while in the USA, this term may also apply to admissions for up to 23 hours. In general, ambulatory surgery is considered when the patient is discharged home before midnight on the day of surgery. And nowadays, this is a common practice even in cesarean sections. What is spinal anesthesia for ambulatory surgery? It is the targeted use of spinal anesthesia in such a way to take full advantage of its many benefits in the day case settings, whilst minimizing the side effects associated with the more traditional approaches. What is fast-track regional anesthesia? Fast-track regional anesthesia means using a non-touch technique to administer a low-dose spinal drug to cause minimal hemodynamic perturbations so that patients can be transferred to the post-anesthesia care unit immediately after the surgery is over. Then why spinal anesthesia is preferred? There is no aerosol, it is not considered as an aerosol generating procedure. There is increased safety, time saving, and low cost. Also, patients may observe the procedure, like in arthroscopies, all patients need to see what's inside their knees or in their joints. Patients may discuss the treatment with the surgeon. This avoids the follow-up visit, less communication with the patient, or less contamination and less exposure to the disease. There is no wake-up or airway removal time. It is safer for recovery and for shorter recovery stay and rapid mobilization, which is very important. And we will discuss, or we will speak about the drugs that can, or that are preferred for this rapid mobilization after spinal anesthesia. As we are in the COVID era, the following should be considered before giving spinal anesthesia. The virus has been isolated from CSF in patients with COVID-19 encephalitis. Therefore, all attempts should be made to avoid contamination by not allowing the CSF to trickle after lumbar puncture. Also, all patients should be examined for a history of lower limb weakness or upper limb weakness or tingling before a block to exclude possibilities of COVID-19 related polyradiculopathy. And this should be documented for medical legal issues. The ideal outpatient spinal anesthetic should provide rapid onset of sensory and motor blocks, a predictable regression of these blocks, and a low incidence of side effects such as transient neurologic syndrome or symptoms. The drug choice, the BUPIVACAINE story. It has been the drug of choice for spinal anesthesia for 50 years. In the hyperbaric form is licensed for use as Marcaine heavy. The isobaric BUPIVACAINE preparation, although sometimes used, but it is not licensed for spinal anesthesia. The LIDOCAINE is another choice license for spinal anesthesia, and the long-acting nature of the BUPIVACAINE has not enhanced the reputation of spinal anesthesia. And this was the main cause of not including spinal anesthesia as a choice for anesthesia in many surgical procedures. Before 1990s, lidocaine was used extensively for shorter procedures. However, it has been abandoned and stopped for the increased incidence of transient neurologic syndrome And this led to withdrawal from the use in spinal anesthesia. The hyperbaric prilocaine, which is the topic of our lecture today, is available now for over 10 years in Europe. It has been introduced last year in our country. It can be used for any surgical procedure lasting about up to 90 minutes, where spinal anesthesia is considered appropriate. Furthermore, up to 120 minutes is possible for lower dermatomal levels if we are using spinal anesthesia for saddle block, for instance. The hyperbaric prilocaine can be manipulated and can be adjusted according to its dose and the patient positioning. For example, a 10 milligram dose in 0.5 milliliter is adequate for perineal block, and a 3 milliliter, which is around 60 milligrams, for periumbilical procedures. Prilocaine is increasingly being used to maximize the benefits of spinal anesthesia whilst addressing the issues of urinary retention, delayed mobilization, and patient satisfaction. The urinary retention and delayed mobilization was the main side effects of using BUPIVACAINE for spinal anesthesia. And this has been compared in a study published in the European Journal of Anesthesia, comparing equipotent doses of intrathecal hyperbaric prilocaine and hyperbaric BUPIVACAINE for elective cesarean section. This study was meant for implementation of enhanced recovery procedures after cesarean section. The main results was the motor block, the median motor block was significantly shorter in the prilocaine group. It lasted around 110 minutes in the prilocaine versus 175 minutes in the BUPIVACAINE groups. The first unassisted ambulation was achieved earlier after prilocaine by nearly 100 minutes, and 1 hour and a half, and the incidence of maternal hypotension was significantly higher in the BUPIVACAINE group. There was no supplementary epidural analgesia in these patients. These patients were anesthetized by combined spinal epidural, and no supplementary epidurals were given to these patients. This study concluded that spinal anesthesia with hyperbaric prilocaine 50 milligram provides faster motor block resolution and better hemodynamic stability than hyperbaric BUPIVACAINE, while offering equivalent qualities of surgical anesthesia and overall satisfaction. Also, considering the potential advantage of faster rehabilitation, prilocaine may be a promising alternative to BUPIVACAINE to investigate through the perspective of enhanced recovery pathways after cesarean sections. This was a meta-analysis about the prilocaine spinal anesthesia for ambulatory surgery published in Anesthesia Critical Care in 2016, and they included around 12 studies. This is the time to void urine was the maximum time, or the maximum time was in 330 minutes for voiding urine, but actually using doses of 60 milligrams or 40 milligrams led to voiding urine in around 2 hours after the spinal anesthesia was given. The incidence of transient neurologic syndrome with prilocaine, it was very infrequent, with a rate of around 0.82% with the prospective studies, and 0.07% when including the retrospective studies. These are the 10 studies, and the first 9 were prospective studies showing an incidence of 0.82%. The last study included around 5,000 patients, but it was a retrospective study. Combining them led to an incidence of 0.07%. Practical issues. In my practice, the dose adjustment is necessary according to the 3 questions that should be answered. Whether is it a saddle block or not? Do I need a level higher than T10 block as for cesarean sections, as an example? Or do I need a duration of surgery is more than 1 hour? If saddle block is the process or the procedure that we are going to do, just 10 to 20 milligrams can be used, especially in perineal surgery, hemorrhoids, and perianal abscesses, circumcision, and valval surgery. If a level of more than T10 block is required, prilocaine 60 milligrams is optimum. This is used for epigastric, umbilical hernia, diagnostic laparoscopy, ureteroscopy, and cesarean sections as well. If the operation will last more than 1 hour, again, 60 milligrams in 3 milliliter is enough. And the examples of surgery that can be used as in anterior cruciate ligament, the bilateral varicose veins, vaginal repair, and colpus suspension. If less than 1 hour, just 20 milligrams, which is 1 milliliter, is enough for supply, for giving anesthesia for level around T8 to T10. In conclusion, ambulatory surgery can be performed effectively with spinal anesthesia. The availability of intrathecal prilocaine had increased the options available to the anesthetist and provide more effective and predictable anesthesia than low-dose and unilateral bupivacaine spinal anesthesia. Also, the adverse effects of ambulatory spinal anesthesia, including delayed mobilization and postoperative urinary retention, are reduced with short-acting agents. Short-acting agents in this case, I mean prilocaine and also chlorprocaine, making spinal anesthesia a safe, effective, and economical alternative to general anesthesia. Thank you very much. It was a very short talk.
Thank you, Professor Dr. Waleed Hamimy. It is a very illustrative lecture. Personally, I've been used tachypril in short procedure like arthroscope. It's a very short procedure, 2 mils is quite enough, and allow very early mobilization and very early discharge from the hospital.
And the most important issue is the time to voiding urine, because especially in arthroscopic surgery, using bupivacaine, I had many cases of inability to void for more than 8 to 10 hours. And I don't know why this incidence or this high incidence occurs, especially in the knee surgery. I tried to search in the literature, and I didn't find a reasonable cause.
I think it's not particular for knee surgery. It can occur with others, but you focus on knee surgery only. That's why you find it. Maybe
because we don't put catheters in these patients. It might be.
Dr. Maher?
Dr. Maher Bey.
طيب دكتور سعد في أسئلة؟
I will see now what is the questions here. Prilocaine in CS, somebody is asking, is it normal, is it safe? Risk of methemoglobinemia?
Methemoglobinemia to occur,
you need a big dose.
We need very high doses, up to 6 milligram per kg. This means 420 milligrams, which is a very high dose that we don't use in practice.
Okay. I think everybody is praising the lecture rather than asking anything. And, I have been here overwhelmed about our colleagues who say, thank you very much for the excellent presentation and well illustrated, and we learn a lot, and all thanks all the stars tonight, because all of us here, we have milestone attendees, all colleagues from all over the world. Are more than 300 colleagues attended this webinar tonight. I think that's the highest attended webinar since we started together, and we are so proud by the stars, the speakers tonight, and the moderators, Professor Maher Fawzi and Professor Muhammad Abdul Rauf. I will leave the conclusion for you, Professor Abdul Rauf, and we will thank everybody. Thank you.
At the end of the day, actually, I'm very happy that attending professors and physicians and colleagues are happy.
Dr. Muhammad, Prof. Maher, Prof. Waleed had
I
a
just
comment.
want to answer a question that has been sent
Okay.
that I didn't include it in the lecture. No need for adding opioids for spinal anesthesia with prilocaine.
Yes.
It's enough to use prilocaine without any additives in our practice. Sorry for the interruption.
No problem. By the end of the day, actually, I'm very happy because we got some positive or a positive feedback from the audience. Actually, all the speakers were to the standard or above the standard. So we have this be with our standard in the future. So thanks to all the speakers. Thanks for the proper and ideal presentations from all of them. So, and I'd like to thank you, Dr. Saad, for your great support and great cooperation and keeping for further cooperation together.